Good morning, everybody. I think it's morning or afternoon. We are so privileged and so excited that today, so this is an early Thanksgiving gift. We are going to have a therapy corner with some therapists at Chatterbox. And they have so graciously have Miss Beth Fleming, who runs Chatterbox, contacted me and said it'd be great for us to get together and have some of the therapists talk about some of those therapies that some of our parents would like to have more information about. So I'm going to introduce these ladies, four wonderful ladies. Miss Courtney is a physical therapy lead clinician. See, I do make mistakes as I'm saying this. Miss Amber is an occupational therapist. Miss Randy is a speech language pathologist. And Miss Christina is a speech language pathologist as well. So I'm going to take this down and we are going to get started.
Good afternoon. According to the American Physical Therapy Association, physical therapists are movement experts who improve the quality of life through prescribed exercise, hands-on care, and patient education. So why would we be important to someone with Down syndrome? Typically, there are changes at the development of the brain and the body, causing intellectual and physical changes when you come to trisomy 21. One of the biggest physical challenges is hypotonia. So hypotonia is called decreased muscle tone. And what is tone? Tone is the amount of tension applies to a muscle. So when somebody is hypotonia, they're considered more floppy. Their muscles are a little weaker and they need a little bit of strengthening. So why would a physical therapist see someone? We would see them for the decreased strength, their excessive movement of the joints, postural and balance difficulties, or challenges with hand use. There also can be some cardiac complications. So as the children get older, it is very important that we work on endurance and improving because the heart is also a muscle. So PT is used to slow down or decreases the chances of later complications. We work on strengthening patients in a pain-free and safe way. Our main goals are to improve muscle strength, balance, coordination, and movement skills to improve independence with daily activities and overall improve the quality of life. Early intervention is actually the most important to do with physical therapy because we want to help promote those skills such as crawling, standing, walking. And an example, I have a baby that I got right out of the NICU. He was 23 days old and he came right here for his physical therapy evaluation. We were able to intervene immediately. We were able to get him in tummy time, work on pushing up, teaching those parents the importance of, not putting them in a container, which is a container would be like the bouncy seat, the swing, what is that? A bumbo. So we want to eliminate those and put them on the floor, get down on the floor with them and do whatever we can. He's now about 15 months and he's already able to crawl. He's pulling to stand, he's standing, and we're currently working on being able to walk. And he can with a push toy and some assistance, but overall he's been doing amazing. And typically I don't get children with Down syndrome until almost 3 because they usually are doing, the in-home therapies. But so to see him making so much progress is really a big sign that outpatient therapy is important, and we can get these guys into doing, skills that their peers can do. And there was something else I was going to go with, but I have to think about it.
No, that's excellent. That's very good. Yeah. So one of my questions is that, give me an example as to, why it's important as far as starting out early through, early elementary school versus someone who hasn't gone through therapies.
So when you are doing early intervention in the clinic, typically they're about 30 minutes, and sometimes we can go up to 2 times a week as the child improves. What's the most important is we have the parent involvement, and we are teaching you how to carry over what we're doing in therapy at home. So it's not just, therapy alone is never going to just fix an issue or, improve a child to optimal level. We need parents to be involved, and we need you to understand what we're doing and seeing what we're doing. So if, with COVID, it's hard to have parents back here. So it's really important for us to take those 5 extra minutes at the end of the session and explain every single thing we're doing, and how they can translate that into the home environment. And because when you're only doing school therapy is incredibly important, but unfortunately it's not a lot of one-on-one time. Where outpatient is geared, it's just me and your child working in 30 to 60 minutes each week. And, I'm gearing towards, because no child is the same. So there's no template with somebody with any kind of disorder, and specifically with Down syndrome. Every child is going to develop their own way. And so all my goals are going to be catered to your specific child and to what they're currently doing and how they're progressing, because some kids are going to excel much quicker and some, take their time. Some kids are a little more stubborn. So the longer you wait, the harder it is, because there's not a lot of resources out there for parents for them to know exactly what exercises to be doing in the home. Especially if this is your first child, you might not know the typical progression of why is it important for this child to crawl before they stand? Why is it important? When should they be doing these things? So it's important to get involved with therapy so that we can educate you and help you along the way, so that you or your child can achieve all these milestones. So when they get to school age, they're not being left behind in the classroom, and they're not just sitting there and not being able to engage with other kids, because, PE isn't the most important, but playing on the playground is. It's socialization. So if they can't do that, then they're kind of stuck to themselves, and you don't want that.
As a parent, I never realized that hypotonia or loose muscle affected everything.
Yes.
So it affects swallowing, it affects speech, it affected gait, walking, and so therapy really kind of strengthens those where they're behind a little bit, or that weakness. Awesome. Excellent.
All right. So in terms of occupational therapy, we help master skills for independence through things like self-care, fine motor skills, gross motor skills, school performance, and then play and leisure activities. So again, like Courtney said, early intervention is absolutely key, and occupational therapy can help a child as early as a couple weeks all the way through their lifespan, which is so cool to see, because you get to see that kid start out at the very small baby infant and then go all the way through like graduating college now and moving on and becoming independent, living by themselves, having a job, and all of those skills. So we can work on, during early childhood, we work on mastering a lot of self-care skills. So those can be things like feeding themselves. Holding a bottle can be really hard for babies with Down syndrome because of that low tone, and a bottle can be very heavy. So we can work on those kind of skills.
Give me a real simple explanation of what occupational therapy is.
Oh, geez, Louise. Okay. So occupational therapy, like I said, so we work on mastering independence. So it's independence with everyday living skills. So don't think of an occupation as a job. A job, when we started our profession, wasn't what an occupation was. It's anything that you do to occupy your time. So those can be the very basic daily living skills of waking up and getting dressed, brushing your teeth, grooming, all the way through school performance once they get to that school age. So then we're looking at fine motor skills. How do they write? How can they type? How can they cut? And going through the life of then, now you're graduated college, how can you live and work by yourself? So teaching those executive functioning skills of managing money and holding a job. How can we teach you how to do all of these things so you can be as independent as possible? So we work more on that functional piece of it.
So is it strengthening as well as coordination?
Absolutely. Yeah. To make sure that we can get through all those skills. So if we're doing scissor skills, I'm not just going to have them cut every single day, because that's good, but we're not going to build up those other skills. We're only going to be focused now on cutting. We'll be really good at cutting, but now we're going to lose all those other skills, that the strength that we need for those kind of things, such as writing. So it's kind of important that we see the child as a whole person versus it just being like, what is the limiting factors? Well, this kid has to go out and be able to do all these skills. So we need to, we'll have goals, but we have also, this is a whole child. So we want them to be successful in everything that they do. So that's kind of where we kind of can come through. So we can work as, like I said, as babies, we're going to be starting with that, holding the bottle, feeding themselves, using a fork, using a spoon. As they get older, we're going to look at more of those fine motor skills, postural control, because one of the big things with fine motor skills is if we have poor postural control, we're not going to have distal stability. So meaning,
As we all sit up straight.
I'm terrible. But if you don't have good postural control, then you're not going to have the support that you need in order to do some of those fine motor skills, such as writing and cutting. So we have to kind of work on everything to get one little thing. Everything goes into it. Your postural control, everything is going to be impacted. And then we look at things like zipping, buttoning, so getting themselves dressed, all the way through learning multiple step tasks. So here at our clinic, we have a kitchen, which is awesome. So we can go through like how to make some simple things with a microwave, how to cook themselves a meal, which is kind of, it's always fun. The kids seem to love that one. That's usually a treat like once a month, because otherwise they do it every time. But it's just kind of, it's important that we help to find ways to help them retain these skills, so that it's not just like a, hey, okay, we mastered this skill and we move on, because if we don't use it, we lose it. So we have to find ways to help incorporate that into their everyday life to make sure that they can be as independent as possible.
Yeah, I find it interesting. My daughter is 17.
Mm-hmm.
She's a sophomore in high school. And for the longest time, when she would write, she'd take up like what is normal 4 lines.
Yeah.
She'd write her name, big.
Yep.
And now at 17, she's finally getting where she's getting into the spaces. And it's just been 17 years of working on that thing,
Yep. And it's hard because it's not something that's, you think it's such an easy fix, but it really isn't. It's pretty complex because there's so many skills that go along with that. You have your visual system, and your fine motor system, and your gross motor, because your postural control. So we have to make all those things work in combination with one another, just to do that simple task.
Very good. Thank you.
Mm-hmm.
Hello. So I am a speech language pathologist, and that is a really long word. And when most people hear speech therapist, they think speech teacher, speech sounds. But our job is, there's a lot of details that we can cover. We cover voice, resonance, oral motor skills, swallowing, receptive language, which is that language, what you're understanding, what you're comprehending, expressive language, which is what you're saying, what you're trying to tell someone, and also pragmatic language, which are those social skills, which in my experience with any individual with Down syndrome, they typically have very high functioning social skills. They're very excited to meet you. They're very excited to love on you. Sometimes it can be not as appropriate because they're so excited. They're so happy. And I was a nanny for a little girl with Down syndrome. And we always said that her extra chromosome was her love chromosome. And
that's awesome.
She was our girl. And so I actually came into the profession of being a speech language pathologist because of Emmeline. And as her nanny, I took her to all of her therapies, and I got to see firsthand what her speech language pathologist did. And to see her progression gave me the urge to want to do that as well. And I think my youngest patient so far has been about 1.5 years. And she came in, she was a very upset little girl, did not want to be separated. And she cried for about 3 months every session. And we have gotten to the point where she goes and she finds the chair that she likes to sit in. She pulls it out. She's ready to work. And she's trying to make sounds now. She is giving us sign language signs to tell us what she wants, or she throws it across the room. But she's made so much progress, and she's trying to tell us what she wants. And she's showing us that she knows so many words. And so we really start off with that receptive language. So what individuals are understanding. And typically individuals with Down syndrome have a higher receptive language ability.
Give me the definition of receptive language.
Receptive language is basically what you're understanding. Understanding vocabulary, understanding nouns, verbs, modifying words, colors. Really just, I always explain it to parents, this is what they're understanding. This is the following those one-step directions, understanding what you mean when you say, let's go to the store. They know, let's go get in the car. They know, when you say, let's take a bath, or when you turn that water on, it's bath time. And then expressive language is basically what they're putting out. It might be screaming, it might be throwing, but that is the way that they are communicating. And as a speech language pathologist, our job is to ensure that individuals know that vocabulary, but not just nouns. We want to make sure that they can say tummy, but also tummy hurt, or big tummy, or red apple, because not all kids like green apples. And so really trying to expand what they know and understand, and how they can request it, how they can comment on things. They are social people, so we're all social people, and we want to be able to interact with other people and interact with our peers. And so just like Courtney was saying, they need to be able to have time to interact with people, whether they have any kind of delay or not. And so we work on starting off with just those basic language skills. What are they understanding? Vocabulary, really lots of imitation. Typically, most of our sessions are play-based, and it's that playing with purpose. Whether it's on the floor, whether it's walking through the clinic, having people yell their name and see if they turn their head, and even sometimes working with other therapists as well. And then moving up to more of those grammar skills, because that's what we found with a lot of individuals with Down syndrome, is that they have all this vocabulary, but they have a hard time putting it together to make good sentences, to make good questions. If they are asking something, to ask that question appropriately. It might not be perfect, but none of us speak perfectly, and that's okay.
So give me an example of that. Do you give them an example and have them repeat it to you?
Well, starting off, for a lot of parents, really any parent that of a child that I work with, especially if they're younger, I show them a pyramid, and it's basically a language pyramid. And at the very bottom, that foundation is attention. You want to be able to get that child's attention, have them paying attention to what you're even doing. The next level is imitation. So with some children, we just start with exclamations like, yay, uh-oh, working on imitating animal sounds, trying to repeat words, trying to repeat strings of words. So it builds up, but really you start at the bottom of that pyramid and you work your way up. And eventually you get to expressive language. We have a lot of parents come in that, I just want my child to talk. I just want my child to say something. And we're working on that all the time. We're constantly talking to children and encouraging parents on how they can speak during their day and really scaffold good language.
Another question I have is that, a lot of our parents, a lot of kids with Down syndrome don't have control of their tongue.
Right.
And so what's the technical term when that sticks out?
I'm not exactly sure the actual term. Do you know that one?
Are you talking about tongue thrust?
Yeah.
Well, basically we're that just because of that low tone. And
so do you do exercises to strengthen
the
mouth?
We do. We can, and Christina will touch more on that feeding and swallowing, but we can also work on those oral motor skills, working on strengthening, working on making specific speech sounds. Because of that low tone, it does make it difficult because your whole mouth is full of muscles. Your tongue is a giant muscle. And so working on different exercises while we're working on sounds. So if we're going to work on lip strength and coordination, we might make a or a p or a b. We don't typically just do the exercises by themselves, because if we just teach a child to go ma, 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 what's the purpose? And so really giving them a sound to make with that. So let's push our lips together hard and then So working on that strength and coordination as well as a functional skill, because they might want to say mama instead of just So really working on that as well. And then as children do get older, we continue to work on those speech sounds. I think I worked with a 15-year-old last week, and we were still working on some of those speech sounds, really just trying to get his speech a little more clear and intelligible so that other people could understand him, because he is a very social fella and he wanted everybody to understand what he said instead of saying, huh, or what did you say? Can you say it again? Because it made him mad. So we work on those sounds. We also work on his social skills. What's appropriate? Is it appropriate to get up on someone or to just hug everyone? Even though you're so precious and sweet, we need to learn those appropriate social skills as well.
How peers would interact in the same space.
Right, exactly. And also, to people that they don't know, that safety component as well. We want to make sure that any child, any adult, whether, regardless of why they're here, is safe, and that they can communicate safely. They can say if something's wrong, something hurts, but also if they're with someone, they're able to know those boundaries and know what's appropriate and not.
What are your thoughts about using as an addendum using sign language in the beginning?
I love it.
Yeah.
And I am a very huge proponent of.
This is all my daughter knew.
I've actually taught it to my own children who they didn't have any language delays, but I have a 13-month-old at home and he does this and he slams the table, and if you don't put food on his tray, you're in for it. But he's immediately I'm a huge proponent of augmentative and alternative communication, which is that AAC. It could be pictures, it could be words, it could just be signs. It can be using a device, an iPad. And there are numerous studies that have found, and I actually put that down here because I wanted to make it a huge point that, and I just lost it completely. There it is. It doesn't hinder their expressive vocabulary use, and it supports the development of their spoken language, because I would never just do this without saying more or without providing more, or I wouldn't just do this and just have them do it and throw them a ball. I would say, oh, you want a ball, you want ball, or ball, please. And it leads you to so many different ways to communicate. I love it.
Yeah. So we're having our Thanksgiving meal tonight, and we're each going to speak about what we're thankful for. And my daughter still has issues with reading. Sometimes it takes her a while to read big words, and she'll come and she'll say, she used to come and say, Dad, she was looking for silver. So she'd say, spell it for me. And I would say, S-I. No, slow down. S-I. She'd write out silver. So the other day, she talked about adaptive, the way to do things differently. She came up and asked me about the movie with Morticia. And I said, The Addams Family. She said, okay. So I followed her back in the room, and she had her iPad, and she said, Addams Family. And it came up on the iPad. And then she went to Netflix and she read and she read off of what she had spoken.
Smart girl.
And I was like, I said, how did you learn it? She said,
I love it.
Anyways, I'm thankful for this year.
Absolutely.
Very good.
Okay. I'm Christina. I'm going to be talking about feeding difficulties, swallowing difficulties, or what we call dysphagia. And I could talk about this all day, so I have a template so I don't get too far off topic. A lot of times we hear the word dysphagia, and it's associated with the elderly. It's associated with people who have had strokes, things like that. We don't always realize that it happens in children too. It happens in newborn babies. So this is a population that's not always tapped into. When we think about the word dysphagia, a lot of people think, oh, they just have trouble swallowing. But it's not just swallowing. So there's multiple phases of dysphagia. So if we have oral phase, that's everything from here to the very back when you initiate your swallow. So if they're not chewing completely, if they're just tongue thumping instead of chewing, if they swallow and they have massive amounts of residue, they're not able to realize that, they don't have the coordination for tongue movements, things like that. That all falls into oral phase. Pharyngeal phase is when we think about swallow. So if they're eating something, drinking something, you're coughing afterward, you have a gurgly voice, you're clearing your throat. Those are all going to fall into that phase. And then we have esophageal. So if somebody has GERD or acid reflux, a lot of times that's a huge indicator that they could have dysphagia. And some of these can go together. So a lot of times if you're not completely chewing up the food that's in your mouth, you go to swallow, what are you going to do? You're going to cough. You're going to bring it back up. So a lot of these can co-occur, but people just don't really realize it. In babies, we talk about oral phase, we're talking about sucking, drinking from a bottle, breastfeeding. That falls into dysphagia. Can we help them? Absolutely. So those are things that we look at. I'm going to give you, just because I'm a nerd, in 2020, we looked at a retrospective study from 2008 to 2020, and it had only Down syndrome children. 89.8. So 90% of the infants had at least one symptom of dysphagia. 72% had just pharyngeal dysphagia. So when they're swallowing, they're having these difficulties. 63% had an impairment in sucking. 62 couldn't form the bolus, whether it's chewing or actually bringing the food together and keeping it together. And 53% had a delayed swallow. Why are you giving me all these numbers? I'm giving you numbers because it actually shows the high prevalence between the two. People don't realize this, but these numbers aren't lying to us. These numbers are telling us this is a common thing. This is happening pretty frequently, and it's not always identified because we don't know exactly what to look for. And that's why explaining what to look for is important. Your child might have tons of residue. I say chipmunking, so they're pocketing food. They've got residue on their tongue. That's going to fall into oral phase, and that's very, very common. So comorbidities that we see with it, we see GERD, the acid reflux. We see any sort of disease or disorder that's going to impair respiratory function. If we're breathing, we're not going to be swallowing. One of the food's got to go in one to the other, either esophagus or trachea. And if you're going to breathe in while you're initiating a swallow, it's going into that airway. Down syndrome is one. Hypotonia, like we've talked about so much, it doesn't only affect gross motor, fine motor skills. It's affecting swallowing. It's affecting talking. These low-tone babies have issues with it. So when we look at preterm babies, when we look at babies that are in the NICU, what are we looking for? Because a lot of Down syndrome babies end up in the NICU. A lot of Down syndrome babies are actually having difficulty drinking from a bottle, breastfeeding. One of my most memorable patients was a baby that I got right out of the NICU, and they had told mom she'll never breastfeed. Don't even try. She's not going to be able to do it. 6 months' time, she was breastfeeding perfectly fine. She went to purees, went to stage 2 foods. 6 months' time. So what can swallowing therapy do for you? What can feeding difficulty therapy do for you? It can bring these children the ability to actually eat and eat safely. If you're seeing the coughing, choking, something's going wrong. Those are signs to us that it's not quite right. We need to fix something. And that's why a lot of people end up going to swallowing therapy. So when we're looking at babies in the NICU, we're looking for, do they have a disorganized suck pattern? Because we want to see suck, suck, swallow, suck, suck, swallow. Okay, is the baby doing suck, 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 swallow, suck, swallow, suck, suck, swallow? That's disorganized. We look at dysfunctional, which is typically co-occurring in babies that have some sort of genetic condition, some sort of disorder. And that's going to be a lot of our Down syndrome children. So they're having tons of spillage, can't get around the nipple, things like that. We're looking at, these are all symptoms of something going wrong. How can we fix this? So one of the importance as well is not only getting them to feed safely, is a lot of these kids, if they're not feeding safely, and that's a progression through pediatrics, they're losing weight. They're not wanting to eat. They end up on a G-tube. Another study in 2018 showed that 15% of the babies in the NICU within the first year of their life, and these are only Down syndrome children, ended up with a G-tube. 15%, that's a high percentage in 1 year. So can they gain weight? Can they eat foods that are appropriate for their age? We don't expect to see a 1-year-old eating only pureed foods, only drinking from a bottle. They're delayed in those skills. And that's where we can come in and help them. Tongue ties and lip ties, huge, huge thing that is always overlooked. And that's a big implication on feeding, sucking, things like that, and we don't realize it.
What is a tongue tie and a lip tie?
Good question. So a tongue tie is when your frenulum, if you take your tongue and flip it up under your lip, you're going to feel that connective tissue. That's your frenulum. When it's too tight, when it's restricted, you don't have the same movement. You don't have the same range of motion with your lips. A lot of times that's going to affect sucking. One of the hallmark signs of a lip tie is, I breastfed and it's horribly painful. They don't take a pacifier. Those are hallmark signs of this happening. A tongue tie would be the same connective tissue. It's too tight underneath your tongue. There's 2 different types. There's the one that you think about, you stick your tongue out, it kind of bows in, makes a heart shape. That's the most common one. And then there's one that restricts the movement back further. That's the one that impacts feeding so much more. They're not able to move their tongue side to side and get that really chewed up. If we're not moving our tongue from the front to the back, that's how our food's traveling. It's traveling all the way back. They don't have that same range of motion, that's impacted. And then when they go to swallow, it could be delayed, or they're swallowing too soon. It's still on their tongues, and it falls back later. Where's it going to go? It's going to go into their airway. So these are all things that can impact feeding, impact swallowing, weight gain, whether or not they get a G-tube. And it is, research shows it's very prevalent in children with Down syndrome. But it's very often overlooked. So it's important to know, we can help. We can get your baby eating. We can get your 5-year-old eating, your 12-year-old eating, because those are important skills. And I always tell people food is love, obviously. And if your 2-year-old doesn't want to sit in a high chair at the table with you, there might be a reason. If they don't want to, if they're not interested in the food that you have on your plate, they might be having discomfort, pain when they're swallowing and when they're eating. They might have a negative connotation with food. So having them at the table is very important. It's family time, it's social time. And those are social skills that we can incorporate as well. But including them in meals is one of the most important things that you can do. On a soapbox. You have any other questions?
No, it's good. I know a lot of our families have trouble with kids. They only eat a certain type of food, and they have texture issues. So, like my daughter can't eat peanuts. She can't eat like pecans because it gets, she just can't keep it in her mouth. But yeah, we have a lot of families that the kids only eat mac and cheese and mashed potatoes.
Yes.
And that's, that they won't eat vegetables or salads. I mean, a lot of kids are that way, but especially kids with Down syndrome.
Absolutely. And OT can work on feeding as well. So if they're only having issues with texture, they don't want a certain temperature, things like that, that's going to be OT. OT is going to handle that. Whereas if they're coughing when they're swallowing, if they're not moving their tongue around, if they still have all this residue, think about it. If you go and lay back, take a nap, where's that residue going to go? It's going to fall right back into your throat, right back into your airway. So those, we can both tag team that. And one of the things you did, you stuck your tongue out as a motion when she's eating. I've seen so many Down syndrome children that do that. They're tongue thrusting. We've got exercises to help with that. And I'll say, try this at home. Let's do this. And it helps to reduce the tongue thrusting, because then you're just expelling food. You're not getting the same amount of food, and you're having difficulty, whether it's getting around a spoon because you're using your tongue to stabilize it, or if you're getting around the nipple and you're using your tongue to stabilize it. There are lots of different things that it can impact, and people just don't realize it. But it's not inherent knowledge. If you don't know, you just don't know what can happen.
So your approach in your field, is it strengthening? Is it like how if they have your tongue tags and
Tongue ties, yeah.
Yeah. So how do you overcome that?
Good question as well. So there are stretches you can do. There are exercises that you can do. Research shows that 90% of kids that had exercises completed pre-op have a better percent of not having the frenulum regenerate, because it can regenerate.
So they'll snip it.
Or they're laser it. A dentist or ENT can do it. And it prevents or helps to reduce the chances of that. And it also, they have a better association and better progression in therapy because they came before they were pre-op. So a lot of times if it's impacting them and they have trouble with lip movements, tongue movements, things like that, that is impacting them, we'll say, I'm recommending that you get this revised. If it's not having an impact, that's not that big of a deal. But if it is actually impacting them, whether it's speech sounds or feeding, we'll say, I recommend you go do this.
So if you have a patient or a person come in and they're having these problems, so you will recommend them to have surgery?
Yes,
Yeah,
I do.
Your
hmm
dentist.
Yeah, and typically they, they'll take the referral, they'll bring them in, they'll look at, oh yeah, that's what they have, and they'll schedule surgery
It's pretty
pretty quickly.
obvious.
And yeah, it's very visible, and typically the recovery time is only 1 to 2 weeks.
Yeah.
So a very short recovery time, pretty simple, but you can typically see a huge difference between pre-op and post-op.
Yeah.
Makes a big difference.
I'm speaking out of ignorance, but it's
No.
funny how everything ties together, right? My daughter's speech, the way she ate when she was a child, all those things kind of go together, and it's all repetitive motions to help strengthen, to help teach the muscles how to work.
And it's really nice being in a setting like this, because we are constantly conversing with each other and collaborating with each other, even if it's not something that I handle directly or OT or PT might handle directly, they'll come find someone. We're not all just doing it on our own. It's really a team effort, and we work as a team here, but also with families. And I love that about being in this specific setting, because if I have a question, I'll just walk the kid down the hall and let's go chat, or bring the parent in.
And I imagine it's pretty quick that you realize that it's something to do with feeding that can affect. You can really kind of.
From a physical standpoint, if they're not feeding, they're not able to gain weight, then their muscles aren't going to be able to be strong enough to do physical exercise. So we need all of each other in order to have a healthy kid.
Yeah. That's awesome. Well, thank you so much.
Great
information. And Miss Beth, would you like to speak as well?
Well, I don't have to.
Well, I would give a plug to if we have people out there that are looking. This is Miss Beth, and tell them where your locations are and how they could. Do they need a referral to come here? How do they come?
Great. So we have 2 locations. We are currently in our Pooler, Georgia location, which is right outside of Savannah. And then we have a second location in Richmond Hill, Georgia. We provide the OT, PT, and speech at both of our locations. We do require a referral from a pediatrician in order to get services started. If families have any questions, they're more than welcome to email me, beth@chatterboxpeds.com, or you can go through our website and just submit a message. It goes to me, and I can help answer questions. We are in network with all Medicaid and CMOs, which I think most children who have Down syndrome have some sort of supplemental, as well as with most of the major commercial insurances as well. And we're always happy to discuss with families kind of what their insurance coverage and things like that would be up front. But we have an incredible team. I'm extremely proud of my girls who are sitting here today talking. I love hearing them talk and just how smart they are.
Yeah.
But I'm a little bit biased. But we have an incredible team. We would love to help your children. Like I said, if you have any specific questions about what we do, how we could help your child specifically, I would be happy to answer any of those questions. And if I can't, I'll put you in contact with someone who could.
So people will put comments in, and I'll refer back to you for answers.
Absolutely.
And we'll also put your address and contact information there as well.
Okay, perfect.
And we're so happy for Chatterbox. They've been such a wonderful supporter of our group, and we're just thankful for that as well.
Yeah.
So thank you, everyone, for today. It was awesome.
Thank you, John.
And as soon as we get questions, I'll let you know.
Okay.
All right.
Oh, probably is in that pocket.